Julie, we can go ahead. Okay.
So thanks everyone for joining us today for our first in our series of webinars. We're thrilled that you could join us today. Just a few housekeeping notes before we get started. If you could advance the slide. Thank you. So you'll notice here that there is an orange button that controls to open and close your control panel. You can use that to slide your control panel forward and back. The next thing is that there is an audio pane, which, thank you. There's an audio pane which provides audio information. By default, you've joined the conference today via a webinar with mic and speakers, and everyone has been placed on mute to maintain good sound quality. So if you prefer, you may join the conference via telephone. Just click on the telephone radio button and the numbers to call will come up there. You may want to use telephone if you're in an area with low bandwidth or if you have spotty internet access. You can change quickly to different listening modes. Also, during the presentation, you have the ability to send questions to our webinar staff through the questions pane, and simply type in your question and click send. We will answer questions that are relevant during the presentation, but we may save the bulk of the questions to the end of the presentation. Also, today's webinar is being recorded and will be shared on the Health Quality Ontario website within the next couple of weeks. All right, so I'd like to introduce our two speakers today. We have Sandy Seaman. Sandy is the team lead for the Best Path program at HQO, and she's a registered nurse with over 20 years of experience in quality improvement and leadership roles. We also have Lynn Dion, who is a manager of capacity building and quality improvement planning here at HQO. She's a registered respiratory therapist and has a Master's of Science in Health Administration from the University of Toronto, and she's certified health executive and is also Lean Six Sigma Black Belt certified. And today our presenters have nothing to disclose. All right, so who's on the call with us today? Currently we have 53 people who have joined the call. We had 100 people register, so there may be some latecomers. Of the registrants, we have about 31 from primary care, 24 from community services, 18 from hospitals, 16 from the LHINs, and 2 from long-term care facilities. So there are 67 of you that are formally associated with a HealthLink, and 6 are informally associated with a HealthLink. So we welcome you all today. If we could just go back to the objective slide. So essentially our objective today is to help participants apply the HQO's QI framework in planning activities that will contribute to the achievement of HealthLink's Year 1 goals and objectives. We're also going to describe 3 evidence-informed improvement packages that can be used by the HealthLinks group. And so without further introductions, I'll let Sandy Seaman take over the overview of HealthLinks for us. Thanks, Sandy.
Julie. Thanks, Julie. We are really excited that you've all taken the time out of your busy days to join us for the launch of this webinar series. Just to level the playing field, it's important that everyone has the same understanding of HealthLinks and Best Path. So we'll start out looking at what HealthLinks are achieving, and we'll also talk about Best Path. After that, Lynn will introduce you to the Health Quality Ontario Quality Improvement Framework. And the reason that we wanted to be sure that you all understood this framework is because it's the underpinning for all the work that we do with HealthLinks. It gives us a really strong backbone as we're moving forward with process improvement. And at the end of this presentation, I'll give you a brief little glimpse into the kinds of supports that we can offer you within your HealthLinks. And I also want to be sure that we have whet your appetite to participate in the webinars that are coming up in the next 6 weeks. So just to level the field for all of us around HealthLinks. HealthLinks were introduced in December of 2012. It's a new model of care at the clinical level. In December, there were 19 early adopter HealthLinks, and today there are 37 approved HealthLinks in Ontario, and the participants are charged with coordinating care at the patient level. The focus in HealthLinks is on improving patient care and outcomes for people with complex health conditions while delivering better value for the investment. The Ministry of Health and Long-Term Care has a system transformation agenda, and HealthLinks are but one part of that strategy. HealthLinks build on existing or new partnerships across all sectors and community support services, including some players that you wouldn't normally see at healthcare tables. Partners like municipal parks and recreation and regional police services. HealthLinks are positioned to forge and strengthen traditional and non-traditional services, taking a more holistic approach to care, ensuring that cultural and social determinants of health are on the agenda. So what's driving this health system transformation? We could have a whole series of webinars on that topic alone, but briefly, we know that we're not consistently providing the care that the sickest people in Ontario deserve. Too many people use the emergency department because they're unable to see their primary care provider. And navigating through the health system is needlessly complicated. When Ontarians are so ill that they can no longer remain in their homes, they find themselves misplaced in acute care beds. And when discharged from hospital, many with chronic illness find themselves back in the emergency department within days of discharge. In the early days of HealthLinks, there are 3 priorities. Each HealthLink is identifying their most complex patients, and they're developing new processes to develop coordinated plans of care with patients and their families. And finally, they're ensuring that all seniors and people with chronic illness have a primary care provider. At the provincial level, activities are focused on clearing the path for HealthLinks to develop and test creative solutions. And electronic support for coordinated care planning is underway, and policy and funding barriers are being identified and addressed. So what are these initial priorities? Well, you can see on this slide that there are 11 indicators of success for HealthLinks. There are 2 operational metrics in the light blue. In the darker blue, there are 6 results-based metrics. And in the final navy blue section, there are 3 evaluation-based metrics. HealthLinks are having their toes held to the fire to ensure that they're addressing the following key indicators. Number 1, ensuring that seniors and people with complex health conditions will have regular and timely access to a primary care provider. Number 2, enhance the health system experience for those persons with the greatest needs. And 3, ensure that all patients with complex chronic illness have a coordinated plan of care. In this honeycomb, you can see a large green hexagon in the middle, and that's HealthLinks. It's supported by more than 25 organizations and initiatives positioned to successfully support HealthLinks. Initiatives such as the Senior Strategy and Primary Care Reform. But you'll see that one of them, the hexagon in the yellow, is the Health Quality Ontario program, Best Path. Best Path offers coaching support to HealthLinks to build quality improvement capacity for those leading cross-sector improvement teams. They're also there to help identify and address gaps in the quality of care and delivery of services for individuals with complex illness. And they do this through quality improvement activities such as value stream analyses. They also facilitate discussions with HealthLink teams about implementing patient and family engagement strategies. And finally, they provide leadership and support to HealthLinks in data collection and measurement and in the implementation of evidence-supported change ideas. And this leads us to the introduction of 3 of our evidence-informed change packages designed to address key issues HealthLinks are facing. Best Path Improvement Packages contain evidence-informed best practices that help HealthLinks achieve their goals. One of these improvement packages, the Transitions of Care document, is the focus for the upcoming webinar series. I'll share more with you about this and the other 2 improvement packages toward the end of the session. Now I'm going to hand the baton over to Lynn Dion.
Thank you very much, Sandy. Sandy's just very nicely laid out the expectations of all of the HealthLinks and the metrics that are going to be an important part of HealthLinks. And of course, there'll be a variety of improvement teams who will be working together now to actually execute on this strategy. And so a coordinated approach to actually improving the quality of care and services that are delivered is important. Health Quality Ontario has developed a quality improvement framework that we believe can assist all HealthLinks teams with meeting their expectations and their goals. And why did HQO develop a framework? Well, there are 3 prevailing improvement models that are currently being used, being Lean, the Model for Improvement, and Six Sigma. And there are a variety of change management models as well as sustainability models that are in use. And we recognize that there has been much confusion in the past, and maybe even in the present, about when to use and how to use these different approaches. And we know that in some way many organizations have used most, if not all, of these approaches. And so our plan was to develop a hybrid that brings together the best of all of these models while closing the gaps of some of the deficiencies of these models. Just want to share that we did review a number of sources and scientific literature to make sure that the hybrid and QI framework that we've developed is based in well-known quality improvement change management science. And so here is HQO's quality improvement framework. You'll notice that the model for improvement underpins this model, and we believe in setting aims, measuring change, and small tests of change are still the right way to accomplish goals. Change management, patient experience, teamwork, and sustainability is woven throughout this quality improvement journey. This is a phased-in approach to quality improvement that can be used in projects big and small. And one of the key limitations of the model for improvement is that it really wasn't explicit about bringing in the voice of the customer and engaging in a relentless pursuit to not only meeting but exceeding customer needs and expectations. By progressing through the 6 phases of this model, we believe that you will gain knowledge about your system, about key processes, where breakdowns occur, and will be able to test changes and potential solutions. In the getting started phase, quite simply, teams are just getting started. They are assembling themselves, getting to know each other, understanding what is expected, what it is they're trying to accomplish, and understanding the current state of the processes and the systems they work in. In the next phase, teams will work to define the problem and build knowledge about key processes and their system by asking questions and beginning to collect data. In phase 3, understanding your system, teams will dig deeper into data analysis and look for opportunities for improvement. Through data analysis, they'll also be able to begin to visualize the ideal future state that will bring value to the people they serve, the people who need and want care. In the 4th phase, teams will have the opportunity to design and test high-impact changes through the plan, do, study, act cycle. And this can be a very exciting phase where teams get to be very creative and innovative and challenge the status quo. Stage 5 involves implementing and sustaining changes that have demonstrated improvement through the testing in a variety of different circumstances and situations. Teams will begin to formally implement these changes and plan for spreading and implementing change across an organization or across a health link. Now we have a short poll for you this afternoon. Based on the very brief and high-level explanation of HQO's Quality Improvement Framework and really an introduction to the different phases of the framework, we'll be very interested in hearing from those of you who are on the call today about where you believe you are in this quality improvement journey based on your HealthLinks work. Number one, being that you're just getting started. Number two, defining the problem, starting to ask questions and collect data. 3 or 4, you are between going into a deep analysis of your data and beginning to identify and test solutions. Or 5 or 6 could be implementing and perhaps spreading change. So Julie, I'll get you to launch the poll if possible, please. Okay, how are our poll results? People voting?
Yes, we have 54% of people who voted now. We'll give it another 20 seconds or so.
Terrific.
Three-quarters of you have now voted. That's excellent.
All right. I think we should be done.
So that's great. So 12% of you not started your QI journey in your HealthLink. 24% of you are in stage 1, which is defining the problem. 24% of you are in stage 2. And 34% of you are in 3 and 4, which is understanding your system and designing and testing solutions. And 5 to 6 of you are implementation and or spread. So that's great that there's such a bulk of groups that have are progressing through their QI journey with their HealthLinks.
Excellent. Thank you so much. And that's really encouraging news for us to hear, because it certainly signals to us that teams are really digging into the work now and beginning to gain some traction and, most importantly, some knowledge about the way that their systems are working and the needs of the patients, clients, and residents who are part of that system. So now that I've given you a very high-level explanation of our quality improvement framework, our slides aren't advancing here. There we go. There we go. I'm just going to spend a little bit of time then showing how the QI framework can be applied to a HealthLink situation. So just over the next 10 minutes or so, we'll dig in a little bit deeper. So in the getting started phase, don't worry. You're already on your way. We saw that from the poll results. Many of you have been here already. You have the high-level goals. They've been set by the Ministry of Health and arguably through the business planning priorities that have been set forth in the HealthLinks business plans. You have your teams, and you've been able to identify the different partners that you are working with as part of your HealthLink. Most of the HealthLinks have identified the populations that need help or the populations that you will focus on. We've just provided 2 examples of how some of those populations might be defined. And importantly, you have the will and the drive to do things better and to collaborate to improve the quality of care and services that are delivered. And again, the Ministry of Health and Long-Term Care has set the high-level goals, and the HealthLinks have set priorities and aims for populations who are deemed to be either high users of services and or high risk of hospitalization or rehospitalization. And let's look at one example from the HealthLinks dashboard that Sandy shared with you earlier. In this case, we'll look at reducing the number of 30-day readmissions to hospital, and this came from one of the results-based metrics. This is a high-level goal that outlines the expectation for a HealthLink, but it really doesn't provide a lot of detail for improvement teams to help really guide the work that they will be doing. And so translating this goal into something measurable and actionable requires an aim statement. An aim statement clearly identifies who is the target of the improvement, how much improvement should be expected, and by when. And aim statements that are set up with this structure are key to aligning the activities of the improvement team. And I hope that you'll see that the aim statement that is presented here, that by September 1st, 2014, we will reduce the number of people with COPD who require hospital admissions by 25%, provides a lot more direction than the rather ambiguous reduced number of 30-day readmissions to hospital. Also in the getting started phase, you'll have an opportunity to identify the current state of the key processes or the value stream. In other words, you'll identify the current state of the end-to-end activities that deliver care and services to the person who has the need. And through value stream mapping, patients, providers, clients, residents in long-term care homes, maybe family caregivers and other stakeholders come together to identify how the process unfolds in reality and to co-design a future state that removes wasteful steps or steps that do not provide value to the customer population that is using or moving through this process. And it's important to recognize that value and experience is defined by the customer. And it's their voice or their perspective that must be captured to fully understand the impact of how care is organized and delivered, and to identify the opportunities for improvement. And in the example that I've shared with you today, some of the experiences that have been mapped onto the value stream are quite poignant, I would say. Some folks are feeling rather shameful at parts of the process. Some patients, clients, or residents are fearful at parts of the process, and they're feeling powerless. And when you look at your value stream and you identify parts of the process that aren't working very well, you might have a lot of wasteful steps, and then you look at how the patient or the client or resident feels in that situation, this could certainly identify parts of the process that are in large need for improvement. We have another short poll for you here. Just wondering, of those of you who are participating today, how many of you have included the value stream mapping exercise as part of your health link planning at the beginning stages? So we'll launch that poll. Thank you, Julie, for launching the poll.
All right, we see that 3/4 of you have now voted, so we'll give it another 15 seconds or so.
Terrific, thank you, Julie. And the poll answers were yes, no, or unsure. And early results are suggesting that about 30% of participants on today's call are not sure whether or not value stream mapping has been included in some of their planning stages for their health link. 45% have said yes and confirmed that in fact they are using value stream mapping as part of their getting started phase, and 25% have said no. The second poll will open. Okay, I'm just going to close this. Of those of you who have included, who have done value stream mapping exercises, how many of you have included patients and or their family members in the value stream mapping exercise? And so we'll just open that poll for a few moments. Again, yes, no, or unsure. So early results are showing that roughly similar numbers to the first poll, that about 28 to 30% aren't certain whether or not patients and or family members have been included in value stream mapping exercises. 46% have confirmed yes, and 25 to 26%, it's toggling back and forth there, are not sure whether, or sorry, have confirmed that no, in fact, patients and their family members have not been included in value stream mapping. So that's quite the spread of experiences out there. As Julie mentioned at the beginning of this webinar, you can submit questions through the technology. So we would be interested in knowing, as I continue to work through this presentation, of those of you who have patients and family members who have been part of value stream mapping, if you might tap in your question through the question box, The value that was gained in including patients, clients, and family members in the value stream mapping exercise. And we'll monitor that section and get back to you shortly with some of the perspectives of yeah. Can anyone hear us?
Yes.
Yes, they're hearing us.
You can hear us. Great. Perfect. Sorry about that. Suddenly we had dial tone on our end, and I think we've been able to fix it. So we had just a little mini vacay for everyone on the line today, and we'll try to get back into that quickly. Okay, so we just, before the little unintended break, we were talking a little bit about some of the activities related to getting started. Moving into defining the problem, you know, you've done your value stream mapping, and you have done some work to capture the voice of your customer and or the experience of the patient's clients and or their family members. So what next? Well, next the quality improvement team that has been employed to work in the health links or organizations will work together to define the problem by identifying why and when the current state does not meet the needs of the people who are seeking care. And this can be done by going to Gemba or going to where the work is done and observing the process. Sometimes that can be done through shadowing patients and family members as they move through the process, shadowing staff to understand the challenges and limitations that staff have to contend with when working through a key process. You can use tools such as the fishbone and 5 analysis to better understand some of the contributing factors and variables to some of the issues that you have been identifying. Teams can also begin to put together a measurement plan, and of course the measurement plan has to be tested. And a well put together measurement plan will help you to collect relevant data and dig deeper into the gaps that have been identified through the value stream. Examples of measures you might want to collect might be the number of complex patients or patients with COPD who have been admitted to hospital. Another example might be the number of of individuals with COPD who are in a primary care practice who may have been admitted in the last 12 months. What type of information is not communicated between providers and how often? Or how long might it take for discharge information to be sent from a hospital to a primary care practice to support continuous care planning? Some of these data, some of this information will be available through administrative data sources, and sometimes we call it stubby pencil work. Sometimes this data and information has to be collected manually, and by using a measurement planning tool such as this one that we've showcased today in the presentation, it helps you really define what needs to be collected, how it's collected, when it's collected, where the information is going to be collected and stored, and who's going to be collecting this information. It could be different shifts, different units on different patients. Okay? And I just wanted to let everyone know that some of the tools that we are sharing with you today are available on HQO's website under the Quality Improvement Planning Framework. Next phase, once your data collection plan has been underway, you're basically going to be implementing your measurement plan and analyzing all of the data that you have collected. And of course, the purpose of measurement and quality improvement is to learn and not to judge. And measures allow us to understand not only the voice of the patients, clients, and residents, but also the voice of the process. And measures tell a story. Goals and targets provide a reference point to evaluate performance. And there are three types of measures that most teams will be working with. One is an outcome measure, which is the voice of the person who needs or requires care. Are they getting the right care? Are they able to access the care that they need in a timely fashion? Are they getting evidence-supported care? Are they achieving better outcomes? Next type of measure would be process measures, or the voice of the process or the voice of the system. In some, are parts or steps of the process performing as planned? For example, our discharge notes being received within 24 hours post-discharge would be an example of a process measure. And then the third type of measure is a balancing measure. And these balancing measures help us understand whether or not there are any unintended consequences, good or bad, but mostly bad, to some of the changes that are being made. An example of that might be activities that are aimed to reduce falls, but a balancing measure might be a sudden increase in the use of chemical and or physical restraints, certainly an unintended consequence. And another key aspect of understanding your system then is the ability then to analyze all of these data and compare it to the value stream and the voice of the customer, and after you validated the value stream then, to design or co-design what the future state process map might look like. And quite simply, a future state map just simply depicts a newly designed process that eliminates some of the wasteful steps that were identified earlier, is more efficient and effective than the former current state that you have. And one of the fun things that is part of this phase, understanding your system, is the identification of change ideas. And Cindy will go into this a little bit more about the best path, certainly the evidence-supported improvement packages, but there are a variety of places to get information and ideas about what changes might lead to the improvements that you seek. So there's guidelines, best practice guidelines, and there's the improvement guide that outlines about 73 different change concepts. You can learn from your peers. What have others implemented, and what results have they gained? You can brainstorm ideas from patients, clients, and residents, as well as staff, and a variety of other stakeholders. And so there are a variety of different places to get change ideas. Your task will be to identify those ones that are deemed to be high impact and evidence supported, and will lead to the changes that you want to make sure that your future state map comes true. In designing and testing solutions, you will consider the details of how a change or an idea for improvement will be deployed. Again, you'll be asking yourself what it is you're trying to accomplish by implementing this change, trying to understand how you will recognize that a change has actually led to improvement. And of course, the third part is what changes can lead to improvement. And you'll be thinking at the local level in terms of impact of some of these changes. And again, you'll be working to make sure that you use the plan, do, study, act cycle. You'll need to plan a change. For example, you might want to be implementing a communication tool to make sure that an individualized care plan moves with a person from primary care to hospital to home. You might be testing this, and it sounds good. However, you need to figure out what the communication will look like, who will do the communication, who will send the communication, who will receive the communication, how it will be sent, etc. And so all of these details are worked out using a Plan, Do, Study, Act tool. You'll conduct a test of change, small test of change, and begin to expand to different circumstances and different experiences, night shift, day shift, weekends, holidays, to make sure that the plan works in a variety of different circumstances before moving on to implementation. Just a couple of sample change ideas that might apply to the target populations that you are looking at through your health links. Again, it's important that before just going straight to implementation, you want to make sure that your your data shows that the ideas that you are testing are actually leading to improvement. And of course, using data over time and incorporating these data into run charts and or control charts will help you tell the improvement story, as this chart clearly shows. There has been improvement and has been sustained. High degree of belief that this change is actually leading to improvement. It's now time to implement. Just a little bit of information here. The whole point of implementing and sustaining change is to make sure that those change ideas that do demonstrate improvement can be sustained across a variety of different units, a variety of different teams, a variety of different organizations. And there's a hierarchy of changes that will lead to or will have a better chance that something will be sustained. At the bottom, you've got checklists and audits and signs and memos, and those things are helpful, but on their own, they're not likely to lead to sustained change. Those types of tools, coupled with visual control, making sure that there are visual ways of showing people the right way of doing things, that we error-proof. We actually make it very, very difficult for people to do the wrong thing. Right? Make it easy for people to do the right thing. And creating standard work documents so that regardless whether you're new on the job, whether you've been doing this for a long time, whether the new process is reasonably simple or complicated, people understand what their standard work is, and we reduce the variation between different groups. Again, you want to, moving up, that coupled with fundamentally changing the process, making sure that the old process no longer exists, that only the new process is supported. And sometimes this is hard because you will find documents and slides and forms and from 5 or 6 years ago still floating around, and people will find a way to bring in some of those older materials. So fundamentally changing the process is key, and that can be done through orientation, through policy changes, etc. And then finally, automate what you can so that it just simply happens wherever possible. And then finally, during, sorry about that. During the final phase, sustained changes are, of course, spread or implemented on a broader scale. And successful spread relies on a culture of the organization, the culture of the health link, and it has to align with the health link vision and the values that have been set forth by the health link. I just want to highlight a few key steps, though. You have to create a spread plan, and again, you have to test the plan and measure whether or not your spread plan is progressing as planned. Spread relies on very good communication, not only within teams, within an organization, but one of the particular challenges with health links is that the communication has to go across organizations and potentially involve dozens of different organizations depending on the size of the health link. And you have to have a measurement plan that clearly identifies whether performance within organizations, between organizations, and across the health link as a whole are actually being sustained, and to identify when performance is dropping off. So this has been a little bit of a whistle-stop tour through the Quality Improvement Framework. Again, many of the tools that I showed you in this part of the presentation can be found on our on HQO's website using this link. So I will hand the presentation over to Sandy again, and she will run through more information about the evidence-supported improvement packages that we have available for you.
Thank you, Lynn. The Quality Improvement Framework will be used in the upcoming webinar series, so you'll be able to see it in action over and over again. We thought it was important that you had this, this overview now so that it would make more sense to you when you participated in the webinars that we're planning. We have 3 improvement packages. The bundles or packages are chronic disease management, supporting health independent and transitions of care. They're displayed in a Venn diagram because many of the concepts and interventions really do apply to more than one of the improvement packages. And each one of these packages describes the source and the strength of the evidence that was used to create the documents. They summarize key concepts, and then the manual actually dives deeper into each change concept, describing specific change ideas, offering tips for successful implementation, and provides a toolbox of resources. Each one of these improvement packages can be used at any phase in the QI journey that Lynn just described. One of the packages is the Supporting Health Independence package. There are 4 key change ideas. They are assessing and remedying safety risks within the home environment, helping the person develop the required knowledge and skills to independently manage their care in the home environment. Third, empowering and motivating the person to take a central role in their health care and creating a safe environment. And finally, implementing the Ontario Health Technologies Advisory Committee Aging at Home recommendations to enhance a person's ability to live independently and safely at home. These include several evidence-informed interventions to reduce the risk of falls, improve urinary continence, alleviate social isolation, and reduce the risk of caregiver burnout. The second in our series of 3 improvement packages is the Chronic Disease Management Improvement Package. It addresses foundational concepts related to effectively meeting the health management needs of those with chronic conditions. These concepts include monitoring a variety of health indicators to optimize therapeutic interventions, as well as the need to reshape that provider-recipient relationship into a collaborative and productive interaction between the care recipient and their family, the specialist, and other healthcare providers. In particular, it recommends that care providers introduce decision support tools at the point of care to ensure that we're delivering evidence-informed care. For example, we should be designing our electronic or paper records to prompt caregivers to include standards, guidelines, and evidence-based care steps. Make it easy to do the right thing. For example, the primary care electronic health record for a diabetic patient should prompt the providers to complete the annual SWOT assessment for diabetics. The second change idea from this package is using information management systems to assist in the development of a proactive planned care approach. Some bright spot organizations in Ontario have designed their primary care electronic records to monitor the key steps in a consultation with a specialist. For example, the system alerts the care team if the time between the request for a specialist appointment and the response to that request exceeds the threshold wait time. This care team then does the appropriate follow-up to ensure that the consultation happens and doesn't get lost in the cracks. The third key change idea in this package is enabling that person to take a central role in their health care. For example, the team can supply self-monitoring logs and tools so that the individual can do assessments at home and then share those assessments and experiences with the care team at their next appointment. The fourth key change idea is providing optimal monitoring and management of chronic and preventive care. Some primary care teams schedule a max pack visit, and the max pack visit maximizes the benefits to the patient. Instead of separate appointments with the nurse practitioner, the dietitian, and the pharmacist, the patient sees all 3 during the same appointment. And the fifth key change idea in this package is integrating specialists and community resources into primary care practices. Some primary care teams have clinic days when the specialist comes to their practice site to assess a series of patients along with other members of the care team. This has resulted in a more coordinated plan of care with the patient while developing the skills of that primary care team. The third improvement package is the Transitions of Care Improvement Package. I won't go into a lot of detail here, but I want to whet your appetite. This is the care package that we are, the improvement package that we're using for the webinar series that's coming up over the next 6 weeks. The key concepts here are 1, individualized care and discharge planning, 2, risk assessment and follow-up care, 3, medication management, and 4, health literacy. Why did we begin with transitions for this webinar series? Well, patients and their caregivers are telling us that they receive wonderful care. They tell us that the care in the hospital is fantastic. They tell us that their primary care provider is wonderful. They say that their home care providers give exemplary service. Where the system fails and when patients are most at risk is in the transitions between the sectors. Improving transitions has been identified by many health links as a problem that they want to correct. So focusing on transitions, we can simultaneously address multiple issues around inefficiency and fragmentation. So this is our lineup for the fall. We have 4 stimulating webinars to further describe the change ideas, to stimulate discussions, and to illustrate Ontario bright spot health links and organizations that have tested the change ideas to improve care transitions for their clients. The first one, Thursday, November the 28th. We're going to highlight the work of Drs. Jocelyn Charles and David Kaplan. Dr. Charles has a special interest in the care of the frail elderly and those with complex chronic illness. She and Dr. David Kaplan have been instrumental in the work with the eHealth Liaison Branch in developing an electronic approach to care coordination. She's currently testing this approach in HealthLinks in Toronto, and her colleague David Kaplan is doing the same in the Central LHIN. On Thursday, December the 5th, Kim Tawana, many of you know her from the Institute for Safe Medication Practices, will be our special guest and will walk us through best practices in medication management, with special focus on some innovative approaches to medication reconciliation in the community and at key points of transition. The third webinar, Wednesday, December the 11th, Kelly O'Halloran, the project manager from Hamilton Health Sciences, will share her experiences in introducing the transitions change ideas as a discharge bundle within the Hamilton Centre Health Link and across the Hamilton, Niagara, Haldeman, Brant, Lynn. She's going to focus on health literacy concepts and how they've been implemented. And our final webinar before the Christmas break will address risk assessment prior to discharge from hospital and developing an appropriate follow-up plan for those identified at being at high risk for readmission to hospital. Our spotlight will shine on Tara O'Brien and on the work that they have done testing the LACE risk assessment tool. Lynn and I sincerely thank you for taking the time out of your busy days, probably spending your lunch break with us during this web-based overview of the Transitions in Care webinar series and the Introduction to Health Quality Ontario's Quality Improvement Framework. We welcome your questions and comments. Put your questions in the question box at the bottom right corner of the screen, and we'll do our best to answer them. Julie, do we have any questions so far from our participants?
We do have one question from Deborah. She's wondering how will the coordinated care plan be integrated into the change packages?
Thank you for that question, Deborah. The principles of coordinated care from the change packages are being applied in the electronic solution to coordinated care. It's a very complex issue, and many of you on the line have been participants in the development of that coordinated care tool. So the short answer to that would be that the improvement package is informing the electronic process, and the electronic process will necessarily also require us to update and refresh the chronic care management improvement package. Any other questions?
Currently, there are no other questions. I'm wondering if any other participants have any burning questions they'd like to ask Lynn and Sandy. Will we have them? People are requesting copies of the presentation, and they will be available on the HQO's website in the Best Path section in the near future. And also a recording of this session will be available as well. Are there any other questions out there? So in summary, we've heard about HQO's model for improvement, which is a combination of the model for improvement, Six Sigma, and Lean. And then we've also heard about evidence-supported change packages that have been developed by Best Path Initiative to support health links in their journey. We have obviously the 4 more webinars that are coming up starting on November 28th, which is a Thursday. And so we're all hoping that you can join us then. And if we have no other questions or any other comments from our presenters, then we will give you back 10, 11 minutes of your time in your day. Anything else? All right then. Thanks very much for joining us, everybody. We're thrilled that so many of you could take time out of your busy schedules to listen in today. Thanks very much.
Thank you.